Okay. So, well, what I would like to do is as we're having more and more people come on, it's 8:05, and I want to be sure that Dr. Armand has the opportunity to give his lecture and then answer questions at the end. Carmel, the first part is in English. We did not expect you to give this talk in Hungarian, although knowing you, you probably could. The second lecture will be in Hungarian. And we've done this for a while. We've been honored to have the top neurologists in the world give lectures every 2 weeks. People that you know very well, Rami Bernstein and Victor Levin and Henry Friedman in neuro-oncology. And Carmel, we've known, Joe Fritz and I have known Carmel for many years. He's our first lecturer from Israel. He's very well known in the American Academy of Neurology and has done tremendous work. He is going to talk about estimating the X chromosome-mediated risk for developing Alzheimer's disease in September. In his CV, I should add that he has trained in America. He's presently the director, he has been the director of medicine in Haifa, Israel. He did his residency in Minnesota at the Mayo Clinic. He trained at Duke University for a fellowship in clinical neurophysiology and then neurology and epidemiology. He's also worked in England for a short course in at Bristol University. And he's a diplomat of many, many societies of the American Academy of Neurology, electrodiagnostic medicine, sleep medicine. He has subspecialty qualification in clinical neurophysiology. I can go on, and he is a gentleman and a scholar. He was a professor at Tufts University till 2013, and presently he's the chairman of the Department of Neurology, Shamir Medical Center in Zerifin, Israel. And it's an honor to have you as a colleague and as a friend, Carmel.
Thank you very much, Laszlo, for the very gracious introduction and all for the privilege of being counted among your friends. It's been a very pleasant experience to get to know you and to learn from you, both in terms of your humanity and in terms of your professional excellence. And again, a delight to be included in the lectures invited to talk within the My Neurosciences lecture series. With your permission, I will share screen show you so that you can see my presentation even as I go through it. Here we go. Thank you. And one more step. Here we go. If anything does not come across well, please let me know. My talk will be about estimating the risk for Alzheimer's, of the X mediated by the X chromosome for developing Alzheimer's disease. I'd like to acknowledge my collaborators in this work. First, Sharon Wolfson, the Neurology Research Coordinator in our department that was part of the discussions that led to the approach that I will be presenting, as well as to gathering the data and its analysis. And then 6 of our 6 memory disorders clinic psychologists, not all at the same time, whose names are listed here, who participated in the diligent evaluation of many of the patients that will be included in this work. This is the outline of my talk, and I'm going to go through a certain amount of background that will explain why we did, because I feel that if I don't explain why we did what we did, it will be as if we pulled a rabbit out of the hat. I'll be starting with a couple of epidemiological tenets, of course, select tenets, then provide specific perspectives on neurodegenerative diseases, dwell on why there is an expectation for the X chromosome to contribute to the risk of developing Alzheimer's disease, bring forth the fact that risks loci for Alzheimer's disease have not been found on the X chromosome, which is the foundation of why do what we ended up doing. So I will introduce the partly new method used in the present study. The reason it's partly new is it's founded in existing methodology, and it's new because it's the first time the existing methodology has been used in this way. And then we'll get into the traditional course of methods, results, limitations, and conclusions that everybody is familiar with. So in terms of epidemiological tenets, the first is that the study of patterns of disease occurrence may lead to clues about disease causation. And again, the may is that sometimes they do and sometimes they don't. But if you persist, the expectation is that they will. And of course, patterns, and this is my editorialization on this tenet, is that patterns may be studied using right hemispheric tools or left hemispheric tools or joint hemispheric tools. And just to give a few illustrative examples, people may remember this diagram of incidence of cholera in 1854, which led Snow to speculate about the role of the Broad Street pump, just by analyzing where people were affected, where they were not, based on distance and competing sources of water, and then coming to a hypothesis that was testable by breaking the handle of the pump. That's John Snow. That's a right hemisphere, definitely a right hemispheric technique. The paradigm for a left hemispheric technique is the work of Doll and Hill in associating smoking with lung cancer. I will pause a little bit on this concept of a 2-by-2 table and the calculation of the odds and of the odds ratio, because we'll be doing that. So you have the phenotype of cases and controls, and then you have risk factors of smokers and non-smokers, and you stratify your phenotypes by the risk factors. Lung cancer cases stratified into smokers and non-smokers, controls stratified into smokers and non-smokers, and then the ratio of odds being a smoker, if you are a case 647 to 2, the odds of being a smoker if you're a control 622 to 27, and then the odds ratio of being a smoker if you are a case or not a case, coming to 14, with the odds ratio, and you see how it's derived. It's this number divided by this number, representing the relative risk for smoking being causal in producing lung cancer. So this is a definite left hemispheric exercise, which leads to the identification. It identifies a pattern, identifies a risk, and can lead to actionable change. This is Hill, and this is Dahl, and this is Hill. And then I'm sure people recall the data gathered by a Hungarian physician at the Vienna General Hospital, showing how in the first clinic puerperal fever and mortality was several-fold higher than in the second clinic. This is, of course, Ignaz Semmelweis, and he used I call this a joint analysis, because, of course, the numbers are pretty much left hemispheric, but presentation appears to the right hemisphere in that we see a graph, and of course that led to actionable interventions to reduce puerperal fever and mortality. The second epidemiological tenet is that causation may be inferred based on analysis of incidence data, preferably population-based, adjusted to age and gender, and not an analysis of prevalence data. And I won't elaborate on this too much, but it is necessary to recall this for the future discussion. And the point is that prevalence data also introduces issues of survival advantage and competing sources of mortality that may interfere with what we see in terms of inferring causation from it, whereas incidence data are not encumbered to the same extent by these other considerations and confounders. Turning now to some brief thoughts about neurodegenerative diseases. It's a group of disorders characterized by the systematic dismantling of neuronal super networks. The phenotype we see, the clinical phenotype, depends on the network or the combination of networks being dismantled, where the dismantling begins and how its progression, its direction within the networks. And as you may imagine, application of classical neuroepidemiological tools to inferring causation in neurodegenerative disease has presented special challenges. I do not intend to elaborate on those challenges, but suffice to say that most of the advances have tended to rely on biochemical approaches, but the biochemical approaches or biological approaches have tended to identify more the patterns of progression of disease after it has begun, rather than the events occurring before the disease is triggered. So this is a gap where neuroepidemiological tools, if they can be applied, can bridge a gap that it's very difficult for biochemistry to cover. The chief reason is that often the cells in which the disease began are deceased by the time the individual is clinically symptomatic. So you're only seeing evidence of disease, process of disease progression, and are not seeing the processes leading to its onset. Three of the best studied neurodegenerative diseases are Alzheimer's disease, ALS, and Parkinson's disease. I've had a long-lasting interest in ALS and the more recent incidence in Alzheimer's disease because I've been holding the memory disorders portfolio at my hospital since the previous holder departed, and there became an opportunity to learn a new field. Now, when we compare from the epidemiological and clinical perspectives, Alzheimer's disease to ALS and Parkinson's disease, we see many points of similarity which suggest similar or shared susceptibility for or pathogenic mechanisms. And here again, a little editorial comment. I make a semantic distinction between pathogenic, which are the processes that lead to and trigger disease onset, and pathophysiological, which are the processes that drive disease progression. And I realize that the two processes, of course, meet, and they meet at a particular cell, but it's convenient to think of what happens before and what happens after using also distinctive terminology, because clearly if one tries to explain disease onset based on the mechanisms driving its progression, one is barking up the wrong tree. And so when we do this comparison, we see many points of similarity, suggesting similar or shared susceptibility factors, pathogenic mechanisms, and a few points where they differ, including one point where they appear to have differed but do not. And so let's take a look at this. Here's a comparison of select aspects of ALS, Alzheimer's disease, and Parkinson's disease. The diseases are listed here. The aspects are listed here. But before getting overwhelmed by the table, I'm going to focus us on four particular comparisons. First, comparison of points of similarity. And so we see that the issue of genetic risk factors in 5 to 10% of patients, early disease onset in most autosomal dominant forms, genetic risk factors for sporadic disease, polygenic, yes, and age-specific incidence increases with age, yes, variations in phenomenology based on site of onset, and variation in phenomenology based on rate of progression, yes. And from all these points, there is one point that is worthwhile carrying forward, and that is that the fact that age-specific incidence increases with age basically obligates there to be a multi-step process, a multi-stage process leading to disease onset, rather than a mere on or off biological change. So this would be more akin to carcinogenesis, but occurring in non-dividing cells. And then earlier disease onset with a genetic predilection would suggest that having a gene for the disease basically saves you a few steps in the multi-step process. So these points of similarity are important, and they provide some insights into how the disease begins before it actually begins. The second point to look at are areas of differences that we will not pursue further today. The issue of there being a peak to age of onset identified in ALS, not so in Alzheimer's disease. I don't have information on Parkinson's disease. And the effect of smoking and incidence, which is similar in Alzheimer's disease and ALS, and is dissimilar in Parkinson's disease. Again, these are differences I will not be dwelling on. The third point to consider is this point, the male to female ratio in age-adjusted population-based incidence. And I'm going to bring this to the forefront in the following slide. As you see, it is 1.5 to 1 in ALS, 1.4 to 1 in Alzheimer's disease, if we are calculating it for amnestic MCI, the earliest clinical phenomenology of the disease, and 1.6 to 1 in Parkinson's disease. Now, the reason this approach to calculating the male to female risk for the disease matters is that the previous prevailing viewpoint was that ALS and Parkinson's disease were more common in men, and Alzheimer's disease was more common in women. And that's correct based for Alzheimer's disease on prevalence. But if one wants to infer incidence, you can't rely on prevalence. And if you infer incidence from prevalence, you get stuck by missing a common feature for the three diseases. Because if you move from to the incidence or the earliest clinical expression of Alzheimer's disease, you find it is present more in men. And so being male is a risk factor for all three common neurodegenerative diseases. Conversely, being female is protective in all three common neurodegenerative diseases. Now, this could be interpreted in terms of differential environmental exposures, or it could be interpreted in the terms of 2 X chromosomes are better than 1 in terms of protecting from the development of all three neurodegenerative diseases, including Alzheimer's disease. The fourth point is a point where ALS and Alzheimer's disease differ, which is that in ALS, as also in behavioral variant FTD, a larger network imposes a greater risk, whereas in Alzheimer's disease, a larger network is protective or infers lesser risk. And this would appear to be a puzzle, or you could say this could be a challenge for some for trying to interpret what does it mean. And so bringing this to the forefront, larger network, more risk, lends support to mechanisms operating randomly, sometimes called stochastic mechanisms, and whereby the greater the target, the greater the opportunity to hit. And the hit would here be produce sufficient changes to trigger disease onset in that cell. Larger network imposing less risk then support to mechanisms whereby the factors that are supportive of greater network development are also protective against its dismantling. This is a completely different sort of idea. It's just different than this one. This pushes things to the developmental or genetic role in protecting or putting at risk, whereas this kind of mechanism places the risk more in time-dependent or environmental factors. I'm not claiming mutual exclusivity, of course, but it's just a matter of greater or lesser weight. And in the case of Alzheimer's disease, this particular observation makes us want to give very strong consideration to genetic or developmental factors, even in causing what would appear to be sporadic disease. And so if we combine clues 1 and 2, the 2 X chromosomes are better, 1 in protecting against neurodegenerative disease, and 2, the genetic factors that are supportive of greater network development are also protective against its dismantling, would lead to the question, does the X chromosome have a role in network developing and dismantling? The answer to this is known, and I will mention it in a minute. And then the second question is, how has the X chromosome been associated with the risk for developing Alzheimer's disease beyond clue number 1? And can we add to what is already known and suspected? And so answering those questions, first, why the expectation for X chromosome, why would we expect it to contribute to the risk? Well, it's been recognized as bearing a disproportionate share of genes responsible for mental function, and it carries perhaps 15% of those genes compared to carrying an overall 4% of the total number of genes in the genome. So it's enriched for genes for network development. The X chromosome is also represented disproportionately in the OMIM listings of genes linked to mental retardation, estimated as 22.3% of the total. We also know of specific X-linked diseases, for example, Fragile X syndrome, Rett syndrome. In Fragile X syndromes, we recognize not only do these people develop differently, but they're also a greater risk for decline from whatever they have attained at an age earlier than the usual individual. Parental lineage has been shown to increase the risk of sporadic Alzheimer's disease in the offspring, with greater risk attributed to maternal lineage. And the risk of maternal inheritance manifests not only in symptomatic individuals, but using imaging or biomarker methods for Alzheimer's disease, also in cognitively normal offspring. So there's reason for us to suspect a role for the X chromosome in Alzheimer's disease. The stark reality is risk loci for Alzheimer's disease have not been found on the X chromosome, and it's not for lack of trying. Initially, it's true that some of the GWAS excluded the X chromosome. Subsequently, they found methods of not excluding the X chromosome from GWAS. But then loci identified in some studies couldn't be confirmed in replication studies. A recent review of the genetics referred to about 40 genes of loci linked to the disease, but none reside on the X chromosome. And other reviews have discussed epigenetic mechanisms whereby the X chromosome might be involved in the pathogenesis of Alzheimer's disease that perhaps elude detection. Of course, there's another possibility for not finding, being able to find risk factors for Alzheimer's disease on the X chromosome, and that it may have no role. Maybe it doesn't have any role in the development of Alzheimer's disease. So that's an extreme position, and we set out to examine it. And in setting out to examine it, I will now introduce a new method and dwell a little bit on that, and then the rest of the representations, they will be relatively piece of cake. And so we sought to estimate the risk for developing Alzheimer's disease mediated by the X chromosome by focusing on a subgroup of clinic patients with late onset amnestic MCI Alzheimer's disease, namely not the people presenting in the 40s who have a stronger known autosomal dominant gene for the disease. And within that group, looking at people with a unilateral ancestral history of Alzheimer's disease or dementia. And we did something that is similar to the Mendelian randomization approach to analysis of the family history in order to try to contribute to infer the contribution of the risk of developing Alzheimer's disease mediated by the X chromosome. And so this is how it looks. We're looking at late onset patients. We're looking at patients in the early stages of the disease, trying to approach the incident state rather than the prevalent state, unilateral parental lineage, and then we're doing some stratification based on proband gender and parental lineage. And this is how it works. We have the probrands, women and men, and we separate them out by those with paternal side affected and maternal side affected. So A, B, C, and D are the number of individuals in each group. For example, these are women with Alzheimer's disease on the father's side of the family. These are men with Alzheimer's disease on the mother's side of the family. It can be the mother or anybody in her lineage. Now, going back to these women with Alzheimer's disease on the father's side, they could get the risk either through the 22 autosomal chromosomes or through the X chromosome. And this is similar for groups A, B, and D. But men with Alzheimer's disease on the father's side of the family, they can only get the risk on the 22 autosomal chromosomes. Okay, so that's the rationale of creating these four groups. And now we're going to see how we can utilize this in order to do a nice analysis that will give me a risk estimate. I just moved the right side of the slide to the left so we can focus here on the right. And so if we calculate an odds ratio, A divided by B divided by C divided by D, that's going to estimate the relative risk confirmed by the X chromosome, because we don't have an X chromosome here. And the method controls for maternal gestational environment. It controls for mitochondrial inheritance. It controls for the Y chromosome effects, if there are any. All these things that I didn't even put into the table get canceled out when we do this kind of calculation. And the second stage is a straight mathematical approach. This estimated proportion of risk mediated by the X chromosome is OR minus 1 divided by OR. And the statistical test for significance for this type of calculation is chi-squared. And so, having covered our background, this is where we proceed straight to our methods, results, and findings. The database that we looked at were the patients who were examined in the Memory Disorders Clinic at Shamir Medical Center between May 15th and September 2020. We included patients with early Alzheimer's disease or amnestic MCI. They were diagnosed according to the usual guidelines. Age was between 55 and 80 years. There were memory problems on only one parental side of the family. This part you've already seen of the statistical approach. And here are our results. Between May 1st, 2015 and September 30th, 2020, we saw 512 patients, of whom 262 were women and 250 were men, so fairly equal representation of men and women, and 441 patients were excluded. You can see the different reasons for exclusion. Some people were excluded for more than one reason. I'd like to focus that some were excluded based on age. And I'm pointing this out because we subsequently did a post hoc sensitivity analysis to see if this particular exclusion affected our findings. We did not do additional sensitivity analyses. Indeed, we limited ourselves to one primary analysis. And the sensitivity analysis was just done out of curiosity to see if we were right or wrong in limiting the ages. And of course, these other make sense. And this is who we found. We had 71 patients, of whom 40 were women and 31 were men. The ages at presentation, 66 years plus minus 5 for women and 68 plus minus 6.5 for men. The difference is not significant. The mean age at estimated clinical onset, 63 for women and almost 66 for men. There is a difference, but it's not significant, and the range is quite large. Mean clinical disease duration at presentation was about 3.1 years. So they were not particularly advanced on the average. 3.1 years for women, 2 years for men. Again, the difference is not significant. And 47 had maternal lineage for Alzheimer's disease or dementia, and 24 had paternal lineage. The ratio here, as you can readily see, is 2 to 1. The Moca Scores, this is the Montreal Cognitive Assessment Test. It's a well-known screening test for people with relatively mild cognitive impairment. And it was available in 61 patients. It ranged from 13 to 29. The median was 23, which represents a mild degree of impairment. Mild degree of impairment. With virtually identical numbers for the 34 women and the 27 men. Somebody has their microphone on. Could that please somebody turn off their microphone, because I am hearing them, as is everybody else. I apologize. Thank you so much. Thank you. And then there were 10 patients in whom we did not have Moca scores, but we had mini mental status exam scores, and these ranged from 13 to 29. Laszlo, can you mediate for me? Maybe the person speaking is Hungarian and does not understand my request in English. Can you please ask people to turn off their microphones?
Could you shut that? One moment. I'm trying to, I think it's Inserica. Could you mute you're talking into the lecture? Get it?
Igen, fejkelés, 11-re ott
I apologize.
I apologize. It's the last one in circa.
Okay.
Mire?
Okay. Yeah, I'm not able to, I'm unfortunately not able to mute this. I'm going to try to continue. Anyway, we saw the following numbers of patients in our groups. We're seeing 18 women with maternal side affected, 22 women with maternal side affected, 6 men with paternal side affected, and 25 men with maternal side affected. The 4 patient groups were similar with regard to the average ages at the presentation of symptom onset. The age at which dementia was recognized in the ancestors, usually the parents, not more distant relatives, were available for 44 patients, and it was 75 plus minus 9 years. That's about 10 years older, actually, than the age at which the average range of the presentation of our probands. And this average age was similar in the 27 patients with maternal lineage and the 17 with paternal lineage of disease. Doing the math, the odds ratio came out to 3.4. The 95 confidence interval is broad. It is 1.1 to 10.1. The numbers are statistically significant, but again, very wide confidence intervals reflecting the small numbers. The estimated proportion of risk in this cohort mediated by the X chromosome comes to 70%, which is extremely high. And I'll be discussing some reasons why that might be so. We did a post hoc sensitivity analysis where we added the 12 individuals who had been excluded from the primary analysis based only on the age, pre-specified age criterion. And without getting into the numbers that you can scan with your eyes, the primary finding remains unchanged. The excluded group appeared to be slightly different than the primary group. And we feel that our age-based exclusion criteria were appropriate, trying to exclude pathological processes that are typically mediated in a different way than that are more autosomal dominant, known to be autosomal dominant, including frontotemporal dementias. I'd like to discuss some of the limitations of the study, certainly not all of them. Of course, this is a database of convenience. It's single sender. It has retrospective design. The data set is based on practice rather than a standardized protocol. It may not be an adequately representative population-based sample. The family history lumps all causes of dementia because it's not possible in such a data set to apply diagnostic criteria to confirm that the affected family members had Alzheimer's disease. The numbers are small, the findings are preliminary, the confidence intervals are wide. And the result is strongly influenced by the small number of men with parental lineage. And this is with paternal, I should say, with paternal lineage. This, of course, is expected, but if the finding was based on a larger number, there would be greater confidence in the observation and greater confidence that it was not just beginner's luck driven by a few patients one way or another. Conclusions, number one, the big one, it needs to be replicated, preferably with larger numbers, preferably population-based, preferably with standardized methods of determining patient and ancestral history of Alzheimer's disease. Now, this is easier said than done because while we do have standardized methods of determining patient history, it becomes a little more challenging to determine the ancestral history of Alzheimer's disease. But having said that, the proportion of risk mediated by the X chromosome in AD or amnestic MCI patients and unilateral parental lineage history of memory difficulties may be considerable. If true, the question arises, why has this escaped detection? And I'm going to throw in a couple of ideas in addition to those that have already been listed that I mentioned a little earlier. Perhaps it escaped detection because the search was diluted by including all people with Alzheimer's disease, whether they did or did not have family history of disease, whereby it would become harder to find an X-mediated list if you're not looking at people with a family history. And in particular, there wasn't a stratification of the search based on the realization that it's more likely to find the risk in some populations than in others, and perhaps that it might be appropriate to program the analysis to take advantage of the fact that there is one population where you're not going to find the risk mediated by the X chromosome, the population of men with a paternal family history, where there are other populations in whom you are going to find the risk mediated by the X chromosome, which is the population, everybody else basically, and who has a unilateral family history. So that might have also contributed to the illusion of detection of risk mediated by the X chromosome. And my final conclusion is that the analytic approach that we just presented could be generalizable to estimating the contribution of the X chromosome in other disorders with complex genetic patterns of inheritance. I'd like to thank you very much for your attention and open the floor for discussion.
Carmel, thank you very much. So has anyone else done this type of work? Because I've not seen this.
Correct. This is, to my knowledge, and I have looked, the first time this method of analysis has been used.
Interesting. For now, at this point, should we be doing something at the clinical level or just wait till the science works it out?
I think anybody who is seeing, who has access to a large population of patients with early Alzheimer's disease, newly diagnosed Alzheimer's disease. And I think the new opportunity that is being presented by the brand new anti-amyloid antibody developed by Biogen is going to drive a huge influx of individuals who are going to be seeking early diagnosis, who are going to be looking for eligibility of treatment. And without getting into the controversy of whether the treatment should be used or should not be used and in whom it should be used, if somebody happens to be in a clinic that is seeing large numbers of apparently sporadic patients, that namely those that do not have one of the known genes, the presenilin or APP1 or APT2, anybody that is in the late 50s, early 60s, they have an opportunity to take a family history. And the family history can be expanded in the sense that you don't just ask anybody in the family has Alzheimer's disease, but you get into some detail about what did the mother die of, how did she die, did she keep her wits about her, what did your father pass away, or has he passed away, and then going to the earlier generations and taking a more diligent approach, an intentional, expanded, I would say, not more diligent, but an intended expanded approach to getting that family history and beginning to accumulate patients. If it's correct that out of 500 patients, only 71 might be informative, well, if you take the long view and many people are collecting patients and you encounter 5,000 patients and it doesn't take you 5 years, but it takes you 2 years to encounter 5,000 patients. And of those 500, you get 700 with a unilateral history, ancestral history of some form of dementing illness. And it's not going to be realistic to completely understand what was the dementing illness in the parent or the grandparent. Then the same analysis could be replicated on a large number of patients to see how the analysis would hold. Would we still see an odds ratio in the range of 2, 2.5, 3, with a larger number, even an odds ratio smaller than 3.4 would meet statistical significance. And if we saw replication with a larger number of individuals, it would begin to increase our confidence in the observation.
Would it be prudent for you to approach Biogen for a grant looking at this? Because at the end of the day, Biogen has been criticized for their science in many ways. This may help them obtain a population that may be worthwhile looking at.
I think that's a wonderful idea. I'll be happy to get some further follow-up ideas from you offline into how to pursue it. One advantage, of course, is that the patients would be amyloid-proven patients with Alzheimer's disease, which is a huge leg up on any other patient population one could think of.
Yeah, Dr. Armon, there is a question in the chat. I don't know if you can see the chat.
Let me go ahead, by all means, let me open it.
Dr. Fritz would like to ask you a question there.
Let me please just first address the chat question because I was asked to do so. And is there anything implied about treatment potential? Not at this point. Not at this point. Let me see if there's another question. That was the question.
Yeah.
Carmel, what I was thinking is similar to Laszlo's question. Biogen is being accused of using a biomarker that in and of itself isn't enough to show that amyloid removal will help. Dr. Masdow has created a point that it might have mixed in to the population of treated patients too many individuals that are too far downstream, meaning that there might be too much tauopathy to reverse. And maybe diluted the numbers. And so I think Laszlo and I are both curious whether or not identifying a more targeted population of where this any treatment protocols might be more successful. Does this analysis perhaps play into identifying the right precise population, or could it down the road?
I don't see directly. I don't see directly how it could identify a correct population or a better population in terms of the criticism raised that when we are making the diagnosis, the disease may be too far advanced to be amenable to respond to treatment in humans by a process that would reduce amyloid or would ameliorate amyloid if there is already amyloid-mediated spread of tau, which is going to proceed anyway, no matter what we do with the amyloid. So the criticism is going to remain standing. And I'm afraid I don't see a direct way of using this approach to identify a more select population that might be expected to respond.
Thank you.
Yeah. Meantime, I wrote a question to you on the chat.
Let me go ahead and open that.
Is it the second X chromosome or the presence of Y chromosome?
I think that the method used cancels out the effect. I mean, I don't think, I know that the method used cancels out the contribution of the Y chromosome.
And the second question, whether you can relate to the estrogen or we cannot relate to estrogen, just X chromosome.
Okay, I think that the method used cancels out the effect of the estrogen because we have females, basically females, A over B is females divided by females. So they're different by who gave them the X chromosome or the autosomal chromosomes, but they're identical on the presence of estrogen. And then C over D is men divided by men. And so they're balanced on Y chromosome and on the absence of estrogen. And so by calculating the odds ratio the way it is presented, we cancel out all these confounders. Any
epigenetical factors?
Well, the issue of how the X chromosome would confer a risk without us being able to detect it, even if it was through an epigenetic mechanism, one would expect that if it was the same mechanism, the same polymorphism operating through an epigenetic mode, then we would have picked up on it. It may not be exactly the same polymorphism. I have a thought which I have labeled just for reasons of having a label. I call it many small changes. And the idea might be that you might have a segment 1 million kilobases long, and a change in any one of those kilobases would give you the same phenotypic impact. But if there's a million of them, a million possibilities, it becomes harder to see that as a consistent change. And if it's 10 million, you begin to have orders of magnitude that might make it elude detection. If it doesn't matter where in a sequence you affect the change for the epigenetic mechanism to take place. Again, this is, I think, more conceptual, and I'm just giving it a label, many small changes, so that I can refer to it in my own mind.
I mean, in order to see the mechanisms more, or do you think that are there good animal models for these neurological disorders? Because there are many animal studies on Parkinson, on Alzheimer. Are they really good for humans?
I think there is an intrinsic limitation in that the animals may not be developing to the same degree the networks that are being dismantled. The timelines may be different. I can say with certainty. I mean, we know that some animals will not develop cancers during their lifetime, so they can walk through a radiated zone and ostensibly not develop any disease because it was going to take the cancer 30 years to develop, but they live for 15 years. That's in terms of simple radiation. In terms of the neural nets, in ALS, for example, you need to have the motor network for the disease of the motor network, or frontotemporal dementia for that matter, to develop. In order for that, you need to be human. And the human internal retrovirus 8, I think, HERV-K, I'm sorry, is necessary for those networks to develop. It makes us different from the chimpanzees. So if you don't have the network, I don't see how you can spontaneously develop the disease of that network, of dismantling that network. When we have animal models, there may be models for the downstream biology of a disease, but it's very difficult to see how they would appropriately represent the pathophysiology. That's for ALS.
Yeah,
I'm afraid I'm less familiar with the utility of the animal models for Alzheimer's disease, except to say that if it's a model in which you implanted a human gene, then you might be creating a model for that human genetic disease, possibly. And again, I'm not sure about that either.
I thought you were going to say that you have to have a baseball player in order to study ALS.
I see.
Yeah,
no, I understand. It helps to give it. I would have to say that it does help to give a human face to a disease that is so difficult to wrap one's mind around, even if one's a scientist, even more so if one's a patient. And I'm grateful for that human face.
Yeah,
he's a very inspiring person. I, of course, didn't meet him myself, but I saw his farewell speech and was moved appropriately.
Yeah. Well, thank you. It was really great, Laszlo.
Well, thank you, Carmel.
Thank you very much.
What time is it in Israel right now? So I know.
It is drawing. It is about 8 minutes to 4 p.m.
Good time.
Wonderful. Well, thank you very much, Carmel. I look forward to seeing you in person, either in Buffalo or at the American Society of Imaging or the American Academy of Neurology. But, we miss our friends. One day, Carmel, we're going to have a symposium at the Mind in Budapest, and you'll be foremost invited to that lecture. So
thank you very much.
So now I will have to inform the audience, the Hungarian audience, that because there have been a change in our talk today, the second talk will be postponed. So there will not be a second Hungarian talk. We'll have that in a few weeks' time, and we'll notify everybody in the audience. Once more, Carmel, thank you for giving us the honor.
Thank you very much for inviting me. A great pleasure and great to see you again.
Very good. Thank you very much.
Bye-bye. Have a very good day and a good weekend.
Thank you.
Thank you.
Thank you.